Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Ladies and gentlemen, welcome to VITALS, Value, Innovation, Technology, Advocacy, and Service. These are the tools that today's leaders are using to transform healthcare. I'm excited today to be able to introduce to you Dr. Michael Forbes, our speaker for VITALS this afternoon. Dr. Forbes is an amazing leader in healthcare. He's the Chief Academic Officer, and he's also the Rebecca D. Considine Endowed Chair of Pediatric Research at Akron Children's Hospital. He's a professor of pediatrics at the Northeast Ohio Medical University in the Department of Pediatrics. As background, Dr. Forbes completed his undergraduate degree at the University of Pittsburgh, and he stayed there to complete his Doctor of Medicine at the University of Pittsburgh School of Medicine before going on to complete his residency in pediatrics and a fellowship in intensive care pediatric medicine at Pittsburgh Children's Hospital. As the Chief Academic Officer at Akron Children's Hospital, he has embraced the challenge of improving childhood health using the tools of discovery, teaching, service, and implementation science. Like all leaders, his approach to leadership and transforming healthcare has been shaped by his personal experiences. Dr. Forbes was born in Kingston, Jamaica, in a large family of 8 brothers and 2 sisters, but he was raised by his mother in Brooklyn, New York, where his early childhood experiences inculcated substantial resiliency into who he is as a person. He has also been shaped by his later experiences, married to Yolanda Moore Forbes, also a physician, and has 2 adult children. But interestingly, Dr. Forbes is also ordained as a Christian minister, and that was back in 1986. Looking forward to hearing about the great work that he has done and how he's used the tools of VITALS to impact change. Dr. Forbes, please come up onto stage.
Thank you, Dr. Lanjo.
Thank you.
Can you hear me okay? Wow. Well, good afternoon, everybody, and thanks for taking time out of your day to be here. I am thrilled to be a part of this. I want to thank Dr. Schmidt for the invitation. I also want to thank Rod Ingram for all of the preparation and pre-work that went into this. I hope it's worth your time. I'm here to really do kind of a quick facilitated discussion and to set the table for further discussion with you online and those of you here live in the audience. And what I'm going to talk about today, I've titled it Perfectly Designed for the 20th Century, the Case for Modernization in Healthcare. Now, we're aware that modernization is happening even as we speak, but I think, and we've seen it from the pandemic, we can move a whole lot faster than we're currently moving. And we can continue to maintain that pace in targeted areas to make a difference for our patients. How do we do that? So one of the features of VITALS is I'm here to speak to you in about 14 to 15 minutes, because that's about how long a physician-patient encounter is here in 2023. So I'm going to do the best I can. What's in front of you now is the recommendations for preventative pediatric healthcare. Do not try to read this. That's not what it's there for. It's really to show you in each column every single visit, from the first prenatal visit all the way up to early adulthood that pediatricians are expected to provide. All of the items are on the horizontal axis, really speaks to all of the elements of a visit from the prenatal visit all the way up to 21. So there's around 10 to 14 items per visit that has to be addressed all the way up until the age of the early 20s to make sure, again, which is the goal of pediatrics, which is to have children who are fully engaged in their families and in their communities. So that's how we know we are winning. And so how important is well visits? Many people take their kids to the pediatrician only because they need to get shots. Well, there's a whole lot more that happens in the pediatrician's office. Those of you with young kids can attest to. So why are they so important? We know because now we screen moms in the pediatrician's office for postpartum depression. And 16% of moms that we screen at Akron Children's have reported symptoms of postpartum depression. 12% of our adolescents that we screen are reporting signs of depression. We also look for insidious causes of disability and disease, like elevated lead levels. If a child's lead level is elevated, there's no way they know certainly, and there's no way their parents will know. So if we don't do this, then we'll miss it. 1 out of 20 kids that are screened have an elevated lead level. And we know that unattended, that will result in cognitive disability as well. 1 out of 20 teens that are screened are positive for signs of substance use disorder. That's 1 out of 20. Now, in my mind, when I think of a teen, 1 out of 20 having these challenges, this is our future workforce. And so if they're struggling in their teens, that means it's a threat to our future workforce, our future employees here at NEOMED and in your organizations. And so we have to catch this so we can mitigate and make a difference before adulthood. Finally, we know that 20% or so of our obese patients are pre-diabetic. In fact, we now see children with significant fatty liver disease as well. And so we're seeing adult diseases in children, diseases, frankly, when I was in medical school, I was not taught about. But we're seeing lots of adult diseases in kids. In the early 80s, probably more closer to the mid 80s, there was this concept of the triple aim in healthcare. It was a framework that we used to think about how we develop strategies and tactics to improve the system. The triple aim really focused on better health outcomes, improved patient experience, because we know that if a patient has a positive experience with their provider, the likelihood of them coming back, following up, being compliant is better. If you have an adverse event or an adverse experience with a provider, you're going to be a little bit reluctant to follow up and even to follow through. We now learned, however, in the early 2000s that a happy, healthy, professional healthcare workforce also results in improved outcomes for our patients and the quality of care. And so now we have the quadruple aim, which is the framework going into the future for how we think about strategies and tactics for healthcare modernization. So of course, we care. We want to reduce the number of kids who have elevated lead levels. We want to attack and reduce anxiety and depression, but we also want to make sure that our nurses and our respiratory therapists and our physicians aren't burned out, depressed, and anxious as well. And so it's a much harder challenge and a much tougher nut to crack, frankly. Our current framework for our healthcare system is that we have a nonprofit system, but it's a for-profit infrastructure. It's really tricky. And so what it creates is a system of what many have referred to as perverted incentives. So while we are noble and we are patient-focused and we really obsess about doing the right thing by the patient, we're also human. And I like to say that humans just, well, we jack stuff up, right? And so I think we have to create incentives in the system that will actually incentivize us to do the right thing by the patient. What you're seeing on your left-hand side is a model from the University of Michigan. There's lots of models about how our health system is designed. It's easy for me as a simple ICU doctor because they all begin with the letter P, right? Payers, providers, and by provider, the University of Michigan's model refers to everyone who touches a patient. So that's the nurse, the doctor, not just folks with prescriptive privileges, but everyone who can impact that patient. And so that's the model, and really, that's really the challenge. But if we follow the money, what do we learn? We learned that in our nonprofit structure with our for-profit infrastructure, we do have, in fact, perverted incentives. There are classic papers throughout the literature. And in fact, preparing for this, I looked to see if we still had this problem, and it turns out we do. Now, it turns out that the earlier part of the system, before we developed HMOs and managed care and all of these things, some of you in this room may remember that era, where you basically was all fee for service. So you did something and you got paid for it, and the more you did, the more money you made. And then the government realized that we're spending an obscene amount of money doing the system that way, perverted incentives. And so we weren't focused on quality. Well, we were focused on quality, but we were really incentivizing the wrong things. So we've changed the system. And how have we changed that system? We know, for example, that when you look at cataract surgery, for example, the number of ophthalmologists in a given census tract determines the rate of cataract surgery in a region. So if you're a solo ophthalmologist, the likelihood of you doing more surgery goes up. As competition goes up in your area, you actually do less and less. Not because there's less disease, but there's simply more competition and less access for you. And so we have to create a system that actually incentivizes the things we want. Now, a lot of this is based on the premise, not to get too theoretical here, on the concept of the social contract. So let me take you back to high school, to civics class, if we even teach that in high school anymore. The social contract is this imaginary philosophical idea that the government has a responsibility for basic services, right? You can see them all in front of you there: police and military protection, the justice system, social welfare. And as a population, we also have an obligation and a commitment to one another, right? And my first commitment is to you as a neighbor, right? And so my behavior, my choices, in fact, affect you. Now, some of us believe very strongly in this imaginary concept, and some of us do not. And we've learned that, right? And so we have to be able to live with that. I wouldn't feel comfortable with you here, those of you here on campus watching us online, if I didn't give you a quiz, right? I mean, Northeast Ohio Medical University, we like doing tests around here. So if you think about it, here's a question. In 2020, and I'll give you the caveat here, this has nothing to do with the pandemic. In 2020, total US spending on healthcare reached what number? 2, 4, 6, or $8 trillion. Now, I can't even count that high, but in your mind, think of the answer. And so here's the answer: $4 trillion. We have been increasing our spending by about $250 billion per year. $250 billion. That's not our cost. That's the increased costs year over year in our healthcare in the United States. That's a staggering reality. Something has to be done. So we're spending $700 million every day. And by the end of this hour, we would have increased our cost, not spend, increased our cost by another $28 million by the end of this discussion. So yeah, I think we have to appreciate the fact that we are in fact out of control. And as someone has said, we got to stop the crazy train. US healthcare spending, according to an article in December 22 Health Affairs, US healthcare spending has doubled between 2000 and 2020. It was 13% of our GDP, and now it's 19.7%. Almost 1 out of every $5 is spent on healthcare in this country. What's really provocative and what these authors showed is that the range of variation across the country is incredible. You can see the average here is around $7,250 at the minimum, all the way up to $14,500 per capita in a state for healthcare costs. Now, why is it twice as high in one state versus the other? Complicated. Cost, average costs, income, the impact of affordable care, the affordable care statutes. But the reality here is that by 2030, we're expected to reach $7 trillion in healthcare spending. And so where's that money going to come from? right? More taxes, frozen wages, because you can't take care of healthcare costs and give raises at the same time. This is real. And so we have to figure out, how do we modernize? How do we change the system and stop the crazy train? So my observation throughout my career, which is about 30 years, has been the system has evolved to be very payer-centric. How many of you are taking care of your parents by show of hands? Yeah, if you handle their healthcare, you know what I'm talking about. I've often said to myself, if my mom didn't have me and my wife and other healthcare professionals in the family, I have no idea how she would navigate Medicare. It is extremely complicated. We have steady increases in per capita costs. Technology has been a blessing and a curse. Now, I'm a techie, love math, love technology. I'm an early adopter. I buy all the stuff that doesn't work and goes out of phase and all that. It is good that I was an early adopter for ChatGPT, though. So there's an upside and a downside. So when it comes to technology, I would submit to you that you have to first have standardization. And that's one of the things that we've learned in healthcare, is that the more we standardize, the better our patient outcomes, but that's not the end of it. So if you're in a healthcare system today and you were awarded $50 million and you can automate everything you do, I would submit to you, you don't want to, because some of your processes are a mess. And if you automate a mess, you end up with an automated mess, and that costs you even more money. So until you have that tens of millions of dollars of an endowment or a gift or a grant, the heavy lifting is now towards standardization. You need human input there. You need to make your processes more efficient. And once they're efficient, frankly, the technology is the easy part. That's where the automation comes in. So let's talk a little bit, as we kind of bend the corner on the end here, around 3 areas where we can modernize. These are the things that, frankly, for me, keep me up at night. I say, how can we use discovery and innovation to improve pediatric healthcare so we can improve adult healthcare? So just so you and the audience can appreciate this, as pediatricians, we fully recognize that the current state of public health is our very public report card. It's how we've been doing for the past 20 or 30 years. So the rates of depression, anxiety, suicide, MI, et cetera, many of those conditions, if not all, begin in childhood. And so if we are unsuccessful at making a difference in children, it absolutely affects adult public health and will affect them for the rest of their lives. Furthermore, remember that the most common medical encounter for half of the population, that is women and women of childbearing age, the most common medical encounter is not with her OB, it's with her child's pediatrician in the first 2 years. And so we're leveraging that relationship because we know that maternal health and child health have a linear relationship. So how do we make a difference in modernization for patients? Well, the image you're seeing here is of an engagement ring. And the reason I put that on there is because we want more patient engagement, but it's more than that. We recognize that the physician-patient, and I'll go a little step further, the patient's relationship to the healthcare system is a critical, a sacred one. It's one that requires intimacy. It's one that requires truthfulness. It's one that needs to be protected. It's special. And as the system evolves, there are normal threats to that level of intimacy in the physician-patient relationship. And so we have to preserve that. So how do we get more engagement, more literacy about how this system actually works? I would submit to you that many people still don't know how this system works. I had a friend recently call me and say, Mike, my daughter's baby is in your ER, not an ER doc, in your ER and hasn't seen anybody for 4 hours. I said, wow, either the place is on fire or maybe they're not that ill and there are other kids that are sicker. I said, have you used our app for the hospital? And they said, well, I didn't know you had an app. I said, tell them download the app. They can talk to a doctor on their iPhone. Oh, really? Yeah, really. They downloaded the app. 90 minutes later, he called me back. He said, that's amazing. They talked with a physician. They got blood work done. They have a follow-up visit in 2 days. They didn't even need to be in the ED. They learned later. So we build these things in our system, and we spend a lot of time, a lot of energy, really smart people creating solutions. But the general population, our patients, still don't know it's there. If you haven't used my chart, please use my chart. It's a lifesaver. It really saves a lot of your time. So as we round the corner, we want to engage patients. We have lots of data that tells us that patient engagement builds trust, enhances communication, improves patient satisfaction, and decreases excess utilization. Get patients engaged. We need to innovate our system. That's the second phase here. So patient engagement and more innovation. Lots of definitions out there about innovation. What is innovation? I'm going to give you the Mike Forbes ICU guy simple definition, right? It is scalable solutions that start with the problem. That's innovation. You can hear ideation to commercialization. There's lots of definitions, but scalable solutions that begin with the problem, which means we start with the patient first and go out from there. We're entering the translational age. And what you're looking at here is the webpage for the National Center for the Advancement of Translational Research. What is translational research? About a decade ago, the NIH, National Science Foundation, and other agencies recognized that we need more translation. In other words, we need to take all of these discoveries that we have and translate them into better public health. As my mentor at the NIH used to say to me, Mike, we are the National Institutes of Health. That H is there for a reason. If it doesn't impact health, we're not going to be interested. I put this up here because this will be recorded. You can go back and look at it in detail, but this is the framework for translational research. T0 is all the way to your left. That's basic science research. It's what I used to do. It's what many of us in the room still do, all the way out to T4, which is public health work. Very, very important model. So the third part, or the third element of modernization, is transformational leadership. We need leaders who are boundary crossers, leaders who are team players, who understand that nothing valuable gets done alone. We need leaders who can look at processes and innovate. Leaders who are domain experts. You do, in fact, need to know your stuff. Leaders who are skilled communicators, system thinkers, and rigorous researchers. I didn't make this up. This is directly from the National Center for the Advancement of Translational Science. This is their model for what a translational scientist needs. And I would submit every transformational leader in healthcare needs all of these as core competencies. So if you don't have them, you're probably sitting next to someone who has one or two or three of them, and you need to find a way to get some mentorship. So what's your call to action? Healthcare modernization has to happen every day. It has to include patients and public health at the center. It has to include translational science as a framework, and it must have transformational leadership as its engine. So in your organization, I'm leaving you with these questions, and that is, how will this impact patients and public health? You have a new program, a new idea, new invention, new process. Will this help patients? Will it improve public health? Have we talked to patients about what they actually need? Because we've learned in healthcare, if you build it, sometimes they don't come. So it's really important to start with patients. How effective are we as health educators and health marketers? And finally, what is my responsibility as a citizen, as a professional, and as a leader in healthcare modernization? Thank you very much for your attention, and I'm looking forward to hearing from you and hearing your comments. Thank you. I want to introduce to this audience our moderator for this session, the rest of the session, Betty Lynn Fisher. Betty is the consumer and medical writer for Akron Beacon Journal.
Thank you. Thanks, Dr. Forbes. Let me set up here a little bit. I'm going to push this forward so I can see. So just a little housekeeping. We are live in person and online. So you'll see there are 4 mics here. If you are here and you have a question, go stand over by a podium, and I'm going to try to traffic cop here a little bit. We'll do some here, and then I've got some online, and I've got some of my own questions. So we've got about half an hour. And by the way, Dr. Forbes, thanks. I've got a story idea from this, because I did not know about the app that somebody could maybe bypass an ED visit. So
absolutely.
story idea out of there. I have my own question that I'm going to start with, which is my chart. So you even mentioned my chart, and even, my kids are 20 and 23, and my chart has grown a lot since then. As a physician, do you tell me some pros and cons? Because as a patient and a patient's mother, actually, I didn't have access to the kids, my chart, it wasn't the technology, but these days you go get a blood draw or you go get an echo and the patient's getting the results right away.
Mhm.
And we don't know anything, right?
Yep.
But now then we're Googling. And
Right.
so I would love to hear pros and cons of that from a physician, because you're probably getting a lot of
Sure.
panicked calls.
Yeah, absolutely. So there was a movement in California years ago, lots of different names for it, but basically it boiled down to nothing about me without me. And the sense there was that there were portions of the medical record that only we as physicians could see, but it was about you. And patients wanted access to all of that. And so that has migrated from California across the United States around the world. And so Epic, Cerner, all of the electronic health records really promote your data about your blood work going directly to you. And it's not uncommon for you to get results as patients before we even see it and have a chance to think about it. And you do have Google, which is good and bad. So my chart is terrific in that respect because it allows you to have what we say an asynchronous conversation, like a text message, like you would with your loved ones. They don't have to answer right away. The physician has an opportunity to look at your chart, put things in context, give you an answer or call you. So that's a really great way of interacting with your physician. The tricky side of my chart is, one, many people don't know how to use it or don't use it. And so there's a lot of other ways of contacting the system that aren't as efficient. And the other side of it, frankly, is the administrative burden on physicians from my chart. My chart, as you mentioned, really kind of has evolved over time. We know how we've taken care of patients historically, and now we have this new digital component to our workday and our workflow that really, for many physicians, many, frankly, contributes to burnout. And so there is some talk about how do we filter that? How do we make that more useful for the patient, as well as not as much of an administrative burden for physicians? But I think we're going in the right direction. It's just, it happened pretty quickly.
So the advice for patients when they see these results and.
Yeah, what I would do is I would use the app and contact your provider and say, hey, what does this blood work mean? And that's really what the app is for. It's for that dialogue.
Sure. Okay, I have a question. Let's go here.
Just want to thank Dr. Forbes for his comments. One pediatrician to another. It was not only music to my ears.
Thank you.
So having gone through this as a consumer, having gone through this as an advisor to parents, children, relatives, having gone through it as a professor trying to teach it, can you comment a little bit about how a system can learn and evolve, an American system can learn and evolve at the public health level in the face of rugged individualism, American, freedom of choice and the desire of Americans to be in control of their own destiny all the time?
Yeah, that's a great question. How much time do we have? Yeah, I think that the divide right now is that we've done some good things. And I think one of the best things we've done is we've democratized information, right? So everyone has access to pretty much everything through Google and other forms of information. The problem with it is that the way I think we as healthcare professionals and the general public thinks about that information is very different. And so we need a way to close that gap so that when you get blood work that doesn't make sense or what have you, you can reach out to your provider because you trust them and you can get it put into context. It's not as simple as looking at the, mayoclinic.com or what have you and looking up your CBC. You really need a provider that you trust who can help you to understand it. One of the problems, to answer your question, Dr. Moad, about the how do we bridge that gap is I think it starts with listening to patients. I also think it includes educating patients as much as we possibly can. And when I refer to healthcare educators and marketers, I'm not kidding. I think we need to market the facts of our system. that people understand that we are an asset. We're not somewhere you go just when you're sick, but we're part of your success team, we in the healthcare system.
Got one back here, and then we're going to go to one online.
Hi, Dr. Forbes. I really
Hi,
enjoyed
Dr.
your thought-provoking presentation. During the pandemic, there was a rapid adoption of telehealth when the country shut down. And while in-person visits have largely returned, do you still see a role for telehealth in the future to improve access to care?
Sure. The question is there still a role for telehealth? After the explosion during the pandemic, is there a role for telehealth? And the answer is absolutely. I think telemedicine is one example of how adaptable we are in our system if we want to be. In December of 2019, the idea of tripling, quadrupling, in some instances increasing by almost 100-fold the rate of telemedicine was unheard of and something we wouldn't have approached in December of 2019. By the end of 2020, everyone was doing telemedicine. So we clearly know how to do this. We need the want to, we need the burning platforms. I think just like many things that happened during the pandemic, telemedicine was a blessing. I don't think it's used as much as it needs to be, but there are areas where I think it has to stay. One area that we know it's invaluable is in behavioral health. I've spoken to developmental pediatricians, for example, who said they've had patients who in their prior visits before telemedicine were mute. They wouldn't speak at all. But in their bedroom or their living room while they're doing telemedicine, they talk, they're much more comfortable. And so for certain conditions and certain diseases, I think telemedicine will never, ever go away. And certainly for those that don't require an emergency visit, but either requires consolation, clarification, comfort, I think telemedicine is invaluable for that.
I'm going to combine two questions from online. So one is, of all advanced countries in 2020, the United States possessed the highest infant mortality rate at 5.4 deaths per 1,000 live births. In such a rich and progressive country, what are we doing wrong? And part B is with 4 of the nation's top children's hospitals, Ohio is among the worst in the US for infant mortality. Shouldn't we be among the best?
Well, I'll answer the second question first, and the answer to that is yes. It's a complicated question, and I think it goes back to a number of factors. When one looks at the social determinants of health, the healthcare component of the 5 represents 20% of the drivers, the determinants of how healthy you'll be as an adult. So there are 4 other components among the social determinants when we talk about them. They include things like justice and transportation and build environment and employment or unemployment, as it were. So there are lots of factors outside of the healthcare sector that determine health. There was an article today, if you can take a peek at just the graphic in the LA Times, that looks at mortality rates in the United States over the past few years. And it shows you that it's not just a pediatric problem, it really is a healthcare system problem. The Southeast has an incredibly high overall mortality rate compared to the rest of the country. And so we have systemic, baked in problems in our healthcare system that are really affected, I think, by the other 4 components as well. We have a job to do in healthcare. Our mission is very, very clear: access, quality, health literacy. That's what we do in our sector. Outside of that, we have to get out of our sector and interact more with law enforcement, interact more with our legal system, interact more with how other parts of the social determinants so that we can actually improve public health. It's impossible for us to be able to move the needle on public health staying in the healthcare sector. We really have to go outside of our sector and partner.
Okay, another one from online. In preclinical research, we learn a lot about health conditions and are able to use what we learn from it to advance basic science. Is it more difficult to discover conditions that impact infants in this way? If so, what are some alternatives?
Can you repeat the question? That's
Sure.
not clear.
Yeah. Do you want me to read the whole thing?
Yes, please.
In preclinical research, we learn a lot about health conditions and are able to use what we learn from it to advance basic science. Is it more difficult to discover conditions that impacts infants in this way? And if so, what are some alternatives?
Yeah, I guess if I can rephrase the question, it sounds like by doing preclinical research, we have a better understanding, or may have a better understanding of discovering disease. My sense is that the basic science can help us discover solutions. And at the clinical trial and the public health level, we see a number of conditions. And I think it's in that sector where we start with the problem, and then we end up going, if you may, backwards on the translational continuum to find solutions. For example, when I was in medical school, there was no such a diagnosis. Dr. Moed, correct me, we're in the same med school, never heard of restless leg syndrome. And suddenly I saw ads, and then I saw a solution for it. And so I think the discovery is happening at the bedside, and then we take it back to the bench, and then we go back to the bedside with the solution. So I think that is the model that really will ultimately impact public health.
This may or may not be something that you just answered here, but it says, please give some examples of the types of translational research at Akron Children's.
Sure, I can certainly talk about what we're doing at Children's. I always use the best model I can think of for how translational research works is the COVID vaccine. It's a real life example of basic messenger RNA research done in a lab in Pennsylvania for a long, long time, decried, right? Because scientists like to disagree with one another. It's kind of in our nature to say that's not true. And so we poo-pooed it and we criticized it, and turns out she was right, everyone else was wrong. And we were able to take that basic science into preclinical work. The pandemic hits, we launched massive international clinical trials. Thank you, Twitter, for getting everybody online, frankly. And so through that work, we were able to finally impact public health. And I still predict that she will probably win a Nobel Prize for saving the world. And so that's a perfect example of translational research. We have to do basic science research. There's no way to ever stop doing that. But the goal, the end game, has to be improving public health. Some of the things we're doing at Akron Children's, I can think immediately about how we think about end of life, which sounds a little bit weird in pediatrics, but children do die. And there's a lot of ways to deal with that space. And what we're learning is that we have to listen to our patients. Again, patient-centered care really begins with the patient. And so learning from the patient and not just building a system of palliative care and hospice care and assuming it works, but listening to the patient, listening to the providers, using the knowledge we already have to improve that system, translating that knowledge, those systems and systems of care into something that actually works for the patient and the family in real time. And so translating that work is not easy, but it's what we do. Another terrific example I could think of is some of the work that was done by Dr. John Clark. Dr. Clark is a cardiac electrophysiologist, so he studies the electrical system of the heart. And it was clear to him that some of the dysrhythmias and abnormal rhythms of the heart that we investigate using radiation so we can see the heart, he was able to figure out a way to not use radiation and not use ablative therapy that may destroy a tract, so to speak, but use cryotherapy that cools the tract to test the tract. So there's reversibility there. And then once, what he was able to do is use that basic science work to now do ablative therapy without radiation, which is very important because pregnant women get arrhythmias as well, and you don't want to expose them to radiation. And so he was able to use basic science and translate it into really just a major upgrade in how that disease is treated, and now that become a standard around the world, straight out of Akron. So pretty cool.
Great. I think we have a question back here.
Thank you, Dr. Forbes. As somebody married to a palliative care doctor at Akron Children's Hospital, I thank you for those wonderful comments.
Sure.
So my question is, how do we market this? So I have a 4-year-old, an 8-year-old, and an 18-year-old, and I didn't know necessarily about how to do the app and how to make to do these conversations that you also experienced a few weeks ago. So what does that look like on a marketing standpoint?
Yeah, that's a great question. You know, I think that all of us, including people who are in marketing and communications at Children's and all of the hospitals, think we're doing everything we possibly can. I still think the secret sauce is hearing from the patients. We build it in our rooms and in our hospitals, and we do get some voices of the patient, but boy, oh boy, we need more information directly from the patients. I'm in a different headspace when I'm a physician than when I'm a patient. And I think the more we can tell those stories and share that, the better, because there is a better system. The access to that system is not nearly as robust as it needs to be. So I would agree with you that we do need to do more marketing, tell those stories, use the social media that we have, and get the word out about the great services that are offered in Northeast Ohio.
And let the Beacon Journal Medical Reporter know about it. So there might be a story in the beaconjournal.com or the Beacon coming soon. Got another question over here.
So I'd like to ask another question about the translational piece, because I think it's really important.
Yeah.
What can we here at NEOMED do to build into our curricula to whet the appetite for students about thinking in a translational matter, and to build the bridge with the clinicians at Akron Children's to have that partnership?
Yeah, great question. So what can NEOMED do to build the bridge and create a greater team, I guess? So my mindset when I think about translational work has really changed. In fact, science in general has changed over the years. I used to think when I was in Pittsburgh that I had to do kind of everything myself. That obviously doesn't work. And so the first thing I think is thinking in terms of what skills do you need around the table? So as a basic scientist, I did it for the love of the game. I mean, I just loved asking the question and seeing the answer. And even if it didn't work out, it was still kind of cool. And what was cool was the community of scientists who would say, wait, that wasn't as bad as you thought. Here's another angle, right? And so you're constantly asking questions and you're constantly learning. However, we're not thinking about healthcare disparities in East Akron, and we need to be, right? And so the team now, to me, is really composed of not only the scientist who wants to do that work, but we also need folks on the team who understand the importance of public health. And when you design your study, to think in terms of, is this addressing a disparity? So if we do studies that only include men or only include women or do not include underserved populations, we're missing out. We're not really getting anywhere. And so I think the next kind of part of that team is the scientists. Of course, we have our biostatisticians, everybody else. I really think we need someone who's thinking like an innovator, someone who understands that scaling this solution for the masses is valuable. Now, as a pure scientist, I don't think about making money from my discovery. That's just not how I think. But someone has to think like that, not in the end of making money, but the idea of scaling it to solve more people's problems is really how we ought to be thinking. And so it is a different way of thinking. And if you don't have innovators on your team, you have innovators here in this organization. And so you have to reach out to them and learn that you need them on your team, because your molecule, your mechanism, your cell line that you think, you know, that's what you're going to do forever, may in fact hold a solution to a huge public health problem that you're not even aware of. And so I would say get out of your narrow little area, be good at what you do, but make sure you're connected, because ultimately the name of the game is improving public health.
Okay, I have a question online having to do with disparities, actually.
Yeah.
Studies show that Black newborns are 3 times more likely to die in the care of white doctors. Solutions include more cultural competencies among physicians and a need for more physicians who reflect the diverse population of patients. Can you comment on these issues and solutions?
Wow, that's a heavy one. So, you know, it's very common when these studies come out. I'll go back when I was a resident. There was a study that came out of Pittsburgh using national data that showed that for long bone fractures, children who were treated across the country, Black children were about twice as likely to have a social work consult and less likely to have pain medication than white children. Now that makes everybody uncomfortable, but that's the data that this is us, right? And the response is typically, well, I don't practice like that. I know I don't practice like that, but the data is what it is. And I think what we need to have is a larger cultural conversation. Remember, we're 20% of the big picture around social determinants. We have to have discussions about race and class and privilege. There are people who don't believe in systemic racism. And I would go out on a limb and say some of those people work here at NEOMED. Some of those people work at Akron Children's. We've not had the real conversation about systemic racism, the impact of history on how we do what we do and how we think. We need to have that conversation. We need to have it professionally. We need to have it with our grandparents. We need to be more progressive and bring the conversation forward. Until then, our lens will remain refracted by history, by culture, by home of origin, and will still not ask the right question. So I think if we're going to correct that refraction, we have to be open and honest and candid that we have a congenital problem in the United States, which is race and racism. It is what it is, but we are moving forward. And I think the more conversations we have, the more we'll begin to understand this. In fact, I tend to not look at the data is what it is, and it says black and white all the time, but we know that it's much more complicated than that, because I don't know if the amount of melanin in my skin is a surrogate for what. I have no idea what that means. And so we really need to go beneath the surface, get beyond race into those other factors. And as one of the attorneys in Cleveland said, if you've ever listened to the Serial podcast, terrific, season 3, take a listen to it. He said, it doesn't help in the legal system to be black, and it doesn't hurt to be white, because we have baked in systemic bias. And so I think we'll start to get answers to those questions around disparity when we start to ask the honest question in an unafraid way.
Thank you. Dr. Langell has a question.
Thank you. Dr. Forbes, I'm going to get back to your initial presentation. And although this is going to apply to all healthcare professionals, you're a physician, so I'm going to use that as an example.
Yeah.
You shared with us that there are 7 critical elements to becoming a transformational leader, and only one of those is domain expertise. Yet the long trajectory in becoming a physician, from the time you start your undergraduate training through sometimes 9 years of postgraduate training,
Yep.
all we focus on is domain expertise. All we test people for is domain expertise. Everything required to become licensed, everything required to pass your boards is domain expertise.
Absolutely.
How do we fit these other elements in? Because there are 6 other components, and time is really, it's a difficult commodity to make use of.
Yeah, great question. You know, I think the challenge in medical education is to really certainly make sure that the domain expertise is there. And I'll make kind of a radical statement here. There are things that I learned in medical school that were a waste of my time. Now, in retrospect, I didn't know that, but I also was a chemistry major, and I use chemistry now in ways that are, I'm just going to say, very different. I take it for granted, right? I think that we have to look at the curriculum and identify those elements that are traditional and historic, but may in fact not add value. And I think as we think about the curriculum and the future of our system, we also want to incentivize those domains, those core competencies that really are what we're looking for in our innovative leaders. We have innovative leaders and transformational leaders here and all throughout Northeast Ohio. I think we want to be able to encourage that in our students and in our learners, that they have to get out of their specific areas and really branch out and reward that and encourage that. I don't know how much time we have to be able to do that, and time is always a factor. But frankly, I think if you surround yourself with people who have those traits, you will learn those traits. And certainly you can learn them formally in a classroom. But a lot of it, I think, is really just creating a community of people around you who have those as core competencies. It starts there.
Okay, I have a question online. Someone said, great talk. We're going to go back to my chart. How might the health system right-size the use of my chart in terms of the 4th goal of the quadruple aim, physician work experience? Currently, the burden on physicians has increased due to many, many my chart contacts to deal with at the end of an already exhausting workday.
Yeah, couldn't agree more. So as I suffer as a surrogate kind of to this, my wife as a pediatrician in primary care has incredible amounts of responses that she has to deal with every day. So I definitely understand it. I'm an ICU guy, so we don't do my chart. So I kind of suffer vicariously in this, and I totally understand it. I'm going to step back and then I'm going to answer the question really quickly. Most of the people who are designing the system and implementing the system for providers do not use Epic. So the architects of the system, the operational leaders in the system, the people who put it around the patient and the doctor don't use it. So that's a fundamental problem in the system. Now we have obviously physicians who sit on these committees and are part of the architectural team, but the design is really not, again, as I said, the people who are designing it and implementing it don't use it every day. And so they don't really know how challenging it is. We've created a system where patients can reach us immediately or asynchronously through MyChart. And right now, I think we're learning that we have to de-incentivize excess use and probably train patients on how to actually use MyChart. I'll give you an example, even in the hospital, because we have the technology, we were texting one another when this texting thing first came out. We were texting securely about patient information. And we were texting things that were that required a phone call in the hospital because there was no formal training on how to use the technology. And so I'm going to go back to what I said earlier. Technology is not the problem. It's almost never the problem. It's the people. And so you really have to educate the people, optimize the process, then introduce the technology. And the problem is technology is way too easy to use. I mean, you can text anybody now, right? But if you don't have the training and you don't have when to use it, when not to use it, we end up installing those after the fact, which is what we're doing now. So one of the healthcare systems here, of course, now starts charging for MyChart answers to de-incentivize excessive use. There's probably a role for AI to filter a lot of that so that the stuff that the physician needs to see gets to the physician. And so there are solutions in the works, but again, the technology is going to come and the retrofit's going to happen after often.
We have another question back here.
Hi, so my name is Cayman Pearsall. I'm actually an incoming medical student here at NEOMED.
Congratulations.
Thank you, which is super duper exciting. But at times I do feel overwhelmed as a student and also as a first gen student and also as a student of color to try and implement some of these important things like advocacy, making sure, I understand material, all of these things that I do want to do. So I guess my question is for you, if you could comment on how you can take what you know now and kind of advise a student like me who's coming into medical school so that I can make these changes, what would you say to somebody like me?
Yeah, that's a great question. First of all, I think my first recommendation as an incoming student, two things, I guess. The first one would be, hear me from my heart, calm down. This is a very friendly environment. The school is designed for your success, not for your failure. It may not always feel that way, especially for the current medical students, year 2, 3, 4, but it's designed for your success. And so that would be the first thing. Keep that in mind, especially when it gets hard, because it's going to get hard. I think the next thing is to find community. I think that is absolutely critical. As a student of color at the University of Pittsburgh, 120 students in the class, it was not easy. But I was able to glom on to 3 or 4 other students of color so that we can share our grievances and encourage one another. So I think it's really important to find community for whatever, your demographic or whatever your identity might be. I think that's really important. And this is a nice, diverse student body. So I think it's good to be able to do that. And then I think find mentors and be a mentor. I think it's important to find people who are ahead of you and also look back and make sure those college students who are thinking about medical school, because you're a role model now, can see you and you can pull those folks forward as well. So actively seek out community, actively seek out mentorship. It's definitely here at NEOMED.
I think I have time for one more question. I realize it is important to curb unnecessary spending in healthcare, but it can be frustrating as a provider to not be able to provide what you believe is the best care for your patients. For example, due to hospital financial hardships and inability to bill for services for our larger Medicaid population, we are unable to expand our vascular access team at this time. How can we best advocate for patient safety and quality care in this financial climate?
Yeah, great question. I don't think there's a single answer to that. I think the approach that I have seen that works, this is one approach, which always seems a bit of an imposition on the people who are saying, how do we do this? How do we get the help? It starts with data. The people who control our finances and are responsible for our fiscal integrity and strength don't do what you do, and they don't know what you do. And so what you have to do is frankly make a business case. And that sounds like kind of an administrative answer. It's not. You have to get the data to show that your implementation, your idea will add value. And I think what I found most impressive when you're thinking about, for example, expanding a service at a hospital, when you think about it, it's not the equipment, it's not the FTE, it's all of it. And so in general, a multi-year, multi-FTE strategic plan gets funded. A request for a 0.75 FTE almost never gets funded because the people who have to make the decision don't have the whole picture. And so the first step is to really begin to gather the data that shows the need and the necessity to fill the gap, because there's not a lot of money. Costs are going up, reimbursements are going down. So it's going to be even more important to be able to build a business case for changes that you want to do in healthcare. Again, not an easy answer, but that's the strategy that I have seen that works. Multi-year, multi-FTE, thought-out plan.
Thank you, Dr. Forbes, for your presentation today and for
Pleasure.
being
Thank
open
you.
to all these questions. I'm going to invite Dr. Langell back to the stage.
Thank you, Betty, and thank you for your expert moderation. Please
you.
join me in thanking Dr. Forbes for this wonderful talk. Thank you. I hope that you will join us next month when we have Dr. Princess Ogu, who is one of our very own, a NEOMED graduate from the class of 2000, who is currently the chief of the Division of Allergy, Immunology, and Rheumatology at University Hospitals Rainbow Babies and Children's Hospital. Until then, stay engaged. You are the transformational leaders of the future. Use the VITALS tools and look out for the best interest of our patients. Thank you.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.